Sure.
Already we have 32 people along with us. So to start your introduction will be quite logical. Dr. Jahangir is going to moderate this session, and he is also a speaker as well. He is going to discuss about the active surveillance. That's a hot topic. I hope we'll learn so many things from him. And the next topic will be the role of surgery or radical surgery in organ confined prostate cancer. This will be done by Professor Sudhir Rawal. Sudhir Rawal is very, very important faculty nowadays all over the world, particularly in the Indian subcontinent. He is very popular. The next talk is going to be given by Dr. Vedang. He is from Tata Memorial Center. He is the head of the Department of Radiation Oncology. He is a very well-known figure in this subcontinent.
Can you see my screen, sir?
Yes, I can see you and I can hear you.
Can you see the screen?
I can see the screen. Welcome. It has been written as welcome.
Okay, welcome you all to this 189th Visits of Multidisciplinary GU meeting of Urology and Transplant Foundation of Bangladesh. UTFB have been conducting this type of meeting each week in the form of, am I audible?
Yes.
Lecture, masterclass, interactive discussion for over 8 years. Due to the present day of reality of pandemic, we are conducting the meeting through webinar. Prostate cancer, as you know, we have been actually discussing the prostate cancer from the last week. It is the second most diagnosed cancer in men, with estimated accounting of 50% of all cancer diagnosed. It has geographical, racial, rural, urban, pathological variations, and there are a lot of controversies on screening, investigation, diagnosis, and modalities of treatment. Today, we will discuss the masterclass on prostate cancer module 2. In this process, we found overwhelming and wholehearted cooperation from faculty from US, India, Bangladesh. We have with us Dr. Sudhir Rawal, Medical Director and Chief of Genitourinary Surgeon, Rajiv Gandhi Delhi Institute, Dr. Mutahar Ahmed from USA, Hackensack University Medical Center, New Jersey, Dr. Vedang Murthy, Professor and Head of the Department Radiation Oncology, Tata Memorial Hospital, Mumbai, Dr. Devnaran Dotto, Head of Radiation Oncology, Amrita Institute of Medical Services, and myself will contribute as a speaker. And as a panelist, we are proud to have again Dr. Professor M.P. Gupta. He is an ex-professor and head of the Department of AIMS and currently working as a consultant urologist at Max Hospital, New Delhi. And Dr. S.A. Khan, Professor of Urology, Popular Medical College, Dhaka, and Dr. Kamrul Jawan Chaudhary, Head of Radiation Oncology, Ahasania Mission Cancer, and General Hospital, Dhaka. This session will be chaired by Professor M.S. Salam. He is the chairman of UTFB and also will act as a member of the panelists. May I also request may I also request participants to take active part in the discussion? Please put your questions in the chat box. May I request each speaker to limit their speak within 15 minutes so that we can invite 1 or 2 questions. And at the end of the discussion, we will have a panel discussions, and each panelist and the speaker will contribute and answer the questions from the audience.
Dr. Jahangir, there is a point that there is a correction we would have to make. We are very sorry that this has been printed like that. Professor Gupta is working in the Medanta group of hospitals, not in the Max Hospital. That's a very important correction that is important.
Okay, we will correct from there.
Yes.
With this, I just want to continue my talk. I just tried to summarize some important points on surveillance, but I think this is a very big topic, very difficult to cover, and this is a controversial topic as well.
So you can start your discussion, and then you will take over the meeting as a moderator. As a moderator, yes.
Just open.
You are on.
Can you see the screen now? Can you see the screen? Sir?
Yes.
Yes, sir, we can see. Yeah, we can see you.
Thank you. So this is my credential, and in this following few minutes, I will try to find out what is happening with the evaluation of the active surveillance as treatment options. What is active surveillance? What are the different guidelines? What are the different guidelines says? And what is the result of different studies? What are the psychological impact on the public in the general population? Is active surveillance varied option in Southeast Asian region? And what is the problem we face in Bangladesh? So if you see how the treatment of the prostate gland evaluates, actually, if you see the history, 1853, John Adams, a surgeon at London Hospital, described the first case of prostate cancer as a very rare disease. You see, 150 years later, the prostate cancer has become a significant health problem throughout the world. There is a dramatic increase in number of prostate cancer. First, the prostate cancer was not differentiated from other type of urinary obstruction until 1990s. And second, the incidence of prostate cancer is increasing more rapidly with the age. Third is the Western lifestyle, all we know. So since the 1980s, we see a lot of things happening. Well, like innovation of PSA, multiple needle biopsy, and screening. These are increases the diagnosis of prostate cancer throughout the world. And if you see the Catalonia, he actually in 1990 actually promoted the prostate cancer screening as serum PSA level. First, it was reported by Catalonia, and he promoted that early diagnosis of prostate cancer through PSA saves life. And this actually adopted rapidly throughout the North America and Europe, and cancer leads to what happened? It overdiagnosis and over-treatment of insignificant disease. Majority of these are microfocal, low-grade disease treated with radical treatment. That actually happened throughout the whole 1990s and early 2020, and throughout the whole world, we see the rise of radical prostitution all over the world. And this leads to considerable morbidity to the men's health problem, as well as sexual health problem and urinary problem. So this actually leads to frustration all over the world among the male as well as the patients. And you can see the newspaper is coming up, media is coming up. Even the man who discovered the prostate cancer, PSA, he said that screening men for prostate, specifically antigen, has become a hugely public health disaster. Then the actually United States Preventive Service Task Force intervened, and they said that PSA-based screening has no benefit or harm. Outweighed the harm outweighs the benefit, and they assigned grade D to the use of PSA-based screen for the prostate cancer, meaning that they recommend against the practice. Somebody can do it, but it is not. That also is a controversy. However, so why this is controversial? Is prostate cancer is different from other cancer, or what is the evidences? So if you see the literature, we have to see the different things like natural history of prostate cancer, clinical evidences, and genetics of prostate cancer. If you see all these things, then we find out what is the difference. As you all know, the prostate cancer is a heterogeneous disease. Prostate cancer arises from genetically altered prostate epithelium and slowly progresses over the several years. The course of the prostate cancer is difficult to predict. Many men not experience any symptom of prostate cancer in their lifetime. And there are some percentages you can see in the opposite studies. 60 to 70% of older men have histological prostate cancer, and prostate cancer is diagnosed only 15 to 20% of the men during the lifetime, 3% risk of death, and only 16% men diagnosed with prostate cancer ultimately die of it. And you can see that even throughout the world, there is a statistic in everywhere. The incidence far outright the disease. The mortality of the disease is far less than the true incidence of prostate cancer. So what are the evidence in the clinical studies? And we have some clinical studies and randomized trial. What is happening? You see that as early as 1994, Jonathan Epstein and Patrick Walsh, they actually published a paper which was actually determining the prostate cancer significance of prostate cancer. Now, it was based on 157 men with clinical SST1 prostate cancer. They started the slide and they found that actually there is actually presence of insignificant prostate cancer in some of the patients. Actually, they said that if the PSA density is 1.0 0.15 nanogram per ml. Biopsy, if it is glycemic less than 6, PSA is fewer than 3 cores in 6-core biopsy, and 50% less than involvement. These are the criteria they fixed out, that they are the they termed it in 1994 that it is a insignificant disease. Later on, DMECO, he actually analyzes the result, biochemical result of after radical prostatectomy. He has external beam radiation therapy, interstitial radiation therapy for clinically localized prostatectomy. They found that there are 3 varieties of prostate cancer. Some of them are very low risk, some of the intermediate risk, some of the high risk. This stratification is still being used nowadays. It was published in 1997. They said that not all prostate cancer are risks. They are, some of them are very low risk. Now, this is a remarkable actually article published by Mr. Egar, Scott E. Egar. He actually is predicting 15 years prostate cancer risk with mortality after radical prostatectomy. If you see the chart he has produced, that when the man with prostate cancer with glycerin 6, they rarely have mortality. Even very near to the 0 is 15%. When the glycerin grade increases, the mortality increases. You can see here. So this is a remarkable study. It was done on large population, around 12,000 people. A confirmed glycerin 6 disease, and 15 years of cancer-free mortality for pathologic glycerin 6 disease was only 0.2%. And one patient in the cohort died of prostate cancer. And they are actually review of the pathology. It was found that that was not actually a glycerin 6 disease. That was a glycerin, actually great glycerin. You can see the 3 nowadays. It is 4+3 glycerin disease. So it appears that the long-term survival of glycerin 6 is almost actually 100%. So what we see what is the chance of lymph node metastasis? There is another study. The Hockman is done in around, they published in very recently in 2012. They said that they actually studied 14,000 cases, and there was positive of, they were all glycerin grade 6 disease or less than that, and they found that only 22 lymph node metastases were there, and they actually reviewed the histological slides of those patients, and they found that they are all the cases they are found to have lymph node metastasis. Actually, they were not glycerin 6 disease. So we can see that from the clinical studies that the chances of metastasis with the glycerin 6 disease is very, very less. And we found some randomized trial. Those also, these are not fit to the criteria of active surveillance. They are done very early in the 90s. One is the pivot trial, and one is the actually SPCG4 from the Scandinavian group. And they found that watchful waiting rather than interventions is almost similar survival. It is not a little bit of more survival benefit in the intervention group, but they are not that big enough. And actually, in the Scandinavian group found that the metastasis related to the prostate cancer is higher in the observation group. So they actually not selected the patients according to the criteria what we said nowadays, but they just selected on the basis of patient wish or stage of the disease. Now again, there's another study in 10 years, which was published in 2016. They said that it was also not a active surveillance follow-up. It was a 10 years actually irrespective of this differentiate into the intervention and radiotherapy and surgery. So that calls active monitoring. In spite of actually watchful waiting only, they turned it as active monitoring. That means they actually monitored the PSA level. If the PSA level is doubling time is very high, very low, then they intervene and do something for them. That study also says that actually there is no significant difference among the treatment, but the metastasis is higher in the non-interventional group. So these 3 studies, they are also they are randomized, but actually, as I said earlier, that they are not fulfilling the criteria of active surveillance. Now, we go to actually molecular biology. What is saying? Now, the hallmark of cancer includes 6 biological capabilities. One is sustained proliferative signal. EGF and EGFR overexpressions, induced angiogenesis, in intensivity antigrowth signal, resistant to cell death, ultimate replicative potential, and activation of the local invasion and metastasis. And you can see in the bracket, we have seen the what is happened to the genetic code, why this is happening. So it's very an excellent review published by one of our son of our soil. He is Professor Hashim U. Ahmed. He is working in Imperial College now, and at the time of UCL, when he was working in UCL, he published a letter in 2012. He showed that this oncological principle, he actually want to fit it into the Syrian 4 pattern. He found that Gleason 3 lesion could be considered as non-malignant. Gleason 4 pattern lesion exhibit most molecular characteristics of cancer. So there's a distinct difference between Gleason 3 and Gleason 4 pattern. So it is apparent from the natural history, clinical and molecular studies that most Gleason 6 cancer have innocent genetic feature, no risk of metastasis. Thus, in the absence of higher grade of cancer, there is little indication for treatment in most patients. So what we have, if we want to do some conservative approach, we have 3 approaches over the last 3 decades. One is phospholyting, as you all know, it's the pre-PSA area. It's a long time ago, started in around 1990. And therefore, in the 90s, we found active monitoring type of things, only the measuring the PSA. And now, since 2001, we are finding active surveillances everywhere. So, what is phospholyting? Refer to the conservative management of prostate cancer until the development of some local or systemic symptom. But we only intervene if there is a local and systemic progression is actually progression occurs. It is not for a curative intent, it is absolutely palliative one. It is given to still given to the patients over 80 or 90 whose life expectancy is less than 5 years. Now, active monitoring was aimed to minimize the risks of hot treatment by avoiding immediate radical intervention by monitoring disease progression regularly based largely on the changes in PSA level. So radical treatment with curative intents could be given necessary. But the other parameter like biopsy parameter and the PSA volume parameter, they don't consider all these things. They only consider changes in PSA level. So now we got active surveillance, and this was actually first formally described by Richard Cow from Toronto, and it was in 2001. That is an active decision not to treat the patient immediately and follow him with close supervision and treat at predefined threshold that classify progressions. Very carefully you look that, but you have to define a threshold level so that we can immediately intervene if there is a sign of progression. So that's a very defined things. We have to follow the whole patients in that predefined threshold things and to find out any progression. So what we see here, we see the clinical stage, PSA value, PSA density, Gleason score, number of pores involved based on 12-core biopsy, and amount of malignancy part. These are the things we see in the protocols. And most clinicians nowadays, they want to do active surveillance when the Gleason score is less than or equal to 6. Gleason stage, clinical stage is less than T2A, and PSA is less than 10, and prostate carcinoma fewer than 3 cores in 10 biopsy core samples, and less than 50% of the core is positive. And they are almost follow the Epstein criteria, which was described in 1994. Subsequently, if some of the cases like Toronto group, they also include Gleason in selected cases, in Gleason grade 3+4 lesions, as well as PSA value of 10 to 20 if the life expectancy is less than 10 years. Some of the other people also follow this criteria, but they are mostly avoided in by the Toronto group. And if you can see the different selection criteria for active surveillance in different universities, like and also John Hopkins, as well as in multi-center European study, also they have their own criteria, almost similar. Some of them are also, they also included Gleason 7 in their inclusion criteria, but not many. So how we follow up? We follow up every 6 months with serial PSA, annual DRE, confirmatory biopsies within 6 to 12 months, if negative. Why confirmatory biopsies? Sometimes we can miss the lesion because the prostate cancer is multifocal one, so you can miss one focus sometimes. So in the meantime, they can increase in size, and we can actually find them by subsequent biopsy. But subsequent biopsy after the confirmation biopsy should be done within 3 to 5 years, and we have to stop doing all these things on the patient which is 80 years of age. We can keep him according to his wish as in watchful waiting, and if the life expectancy is less than 5 years, we can stop doing biopsies. And you can see the guidelines in different ASCO, NCCN, NICE guideline. And you can see, and cancer care oriented as well, the active surveillance is preferred treatment when the disease is low risk cancer. And you can see all of them, most of them, they actually took active surveillance as a first line of treatment for low risk cancer. And the follow-up protocol almost same. And actually, some of them recommend MRI in their follow-up if they find something odd in the pathology on the actually the upgrading in the biopsy. They also do an MRI to see the extent of the disease. So what are the risk factors beside the biopsy factors, like increasing PSA density, increasing it is chance that there is a chance of biopsy reclassification. That means that if we see the increased density and volume of the prostate, then there is chance of biopsy reclassification. Impact of the race. Several studies previously shows that if in case of African American man, that the chances of higher grade disease is more. But recent studies shows that they are not, because if we provide them an equal opportunity, then the chances of malignancy or high grade disease is become equal in both African and white man. And younger age has low risk of staging upgrading, but you need to follow up for a long time. But because at the later age of their life, in the 60s and 70s, they can develop high grade disease. Is there a role of MRI? Multiparameter MRI result demonstrated sensitivity and specificity and positive predictive value. Native all are in favor of diagnosis of prostate cancer, but it still cannot replace the biopsy as a biopsy follow-up as in active surveillance patients. Biomarkers, there are some recent biomarkers are coming up, but use of their use in the active surveillance protocol is still not recommended. Sort of the outcome. If you see the Toronto University protocol and Hopkins protocol, you can see there are around 1,000 patients. Both of them, they have 5 to 6 years of protocol. It was taken in and then you can chances of survival is almost overall survival is almost 65% on active surveillance. And some of them are follow the strict protocol. They said the overall survival is 99%. So we can see that this is a very good data, and there is other data is also available in UA guideline, and you can see that a lot of persons are and institutes doing it, and their overall survival is nearly 90 to 100% on active surveillance. So what about the quality of life among the men receiving active surveillance for prostate cancer? So actually, this is a study, and it was actually a review study, and it is on 37 articles, indicate the low level of anxiety and depression and decreased incidence of bladder, bowel, or sexual functioning among men undergoing active surveillance. That means in men who are receiving treatment and not receiving treatment like active surveillance, the quality is not differ. But they are even better. But opposite to that, there are some study says that the patient who is having active surveillance, this suffers with higher anxiety than the patients who are having treatment, like definitive treatments. So they recommend that more and more studies done is necessary to know the psychological status of these patients, what happened after active surveillance. Is active surveillance a valid option in Southeast Asian region? Most observational studies we have seen, their cohort did not include, actually barely include men from the India or Bangladesh descent. So many recent studies on active surveillance suggest Asian people show more aggressive clinical feature, extracapsular extension, positive notes, higher chances of apostasis upgrading over their Western counterpart. So basically, we have to be very careful. Very recent publication from the Gautam and others that there is a 50% of likelihood of apostasis upgrading in Indian males with low risk prostate cancer eligible for active surveillance. This study was done from the cohort of radical prostatectomy patients who actually initially they found to be a very good for candidate for active surveillance, but even then they undergone they failed all the criteria of active surveillance. But when they have gone for prostatectomy, they segregated that cohort and found that the 50% of them actually found to have apostasis and upgrading. So problem in Bangladesh, the presentation is late in Bangladesh. Late population screening program is not feasible or affordable. Quality of histopathological reporting and tumor grading in biopsy is questionable in this country. We don't get any standard report from every pathological lab. Reporting of multiparametric MRI is also sometimes critical. Illiteracy, non-compliance, and unawareness of the disease and its consequence among the people, and understanding the patient need for surgery or radiotherapy in any time in future, there is a problem. Non-compliance for follow-up and record keeping to avoid medical legal consequences is also a problem. So conclusion, active surveillance is a new strategy that aims to individualize therapy by selecting only those men with significant cancer for curative therapy. It has already established it as a treatment modality for low-risk prostate cancer in the West. But in the Southeast Asia, including Bangladesh, we must be very cautious about the taking decision to keep a patients on active surveillance to avoid confusion and unnecessary overall treatment. Lastly, I must say, again, this is very known word to everybody, prostate cancer is the only human cancer that is curable, but which commonly does not need to be cured. Thank you very much for patience hearing.
Thank you, Dr. Jahangir.
Sir.
We have Professor Mark Soloway from US. You can welcome him in favor on behalf of everyone, and fantastic. you can ask a little opinion or a comment. Hi, Michael Soloway. Mark Soloway, please.
I can look at him.
I thought that was a superb overview. Excellent talk. I've been an advocate of active surveillance for 15 or 20 years.
Right.
The only thing I would mention is my personal way I follow is every 4 months because I think they're anxious, and I look at the PSA. I agree that the DRE isn't terribly helpful, but the patient expects it. I don't use MRI, probably one of the few that don't think it's critical. I think the PSA stability, as mentioned by the speaker, is really important. If the PSA is absolutely stable, you have to remember that in the US, a lot of men get biopsied with the slightest increase of PSA. So I have people in active surveillance that start out with a PSA of 1 or 2, and they had a focus of Gleason 6. And as long as that PSA stays very low, I see them every 4 months. I have a number of these people, 10 or 15 years. And I emphasize to these patients right from the beginning that I promise you, you are not going to die of prostate cancer. And as soon as you say that, and you can provide some literature that immediately takes away the concern that the man who walked in with a new diagnosis of prostate cancer thought he was going to die within a year, now feels very comfortable and with your assurance. So I thought that was a wonderful talk, and I'm glad I was here to listen to it.
Professor Professor Salo, I have got a little question. In your practice, do you use the 4K and PHI test for active surveillance follow-up?
The answer is no, I don't use either one. I do use the free and total for some patients.
Okay.
I think the free PSA adds something, but no.
Okay, thank you. Dr. Jahangir, please.
Thank you very much for patient sharing, and I should not take more time now. I just want to opt it out from my screen, and my next my next speaker is Dr. Professor Vedang Murthy, and he will be talking on no,
Overview of radiation therapy
no,
used in the localized prostate cancer.
No, sir. Yeah, I'm sorry about that. This is Dr. Sudhir K. Rawal. He will be talking on surgical treatment for organ-confined prostate cancer. May I request Professor Dr. Sudhir Rawal to come up and
sure. Sure, Dr. Jahangir. Can you unshare? Can you stop sharing?
Just going to find out where it is.
Must be up. Go up.
Exactly. Fine.
Yeah.
Fine. Thank you.
Okay. Thank you, Dr. Jahangir and Dr. Salam. Thanks a lot for inviting me for this talk to give on surgical treatment of organ-confined CA prostate. I'll go through my presentation and then can you see my screen?
Yes, it is.
Okay.
Just come up.
Yeah. So after that, I'll show you one video of robotic prostatectomy. Now this operation, if you see the anatomy and physiology, this Journal of Anatomy and Physiology, long back in 1905, you can see that how the prostate was described as a anatomic books like egg lying in egg cup only attached to the apex. And this is how the people thought in 1905 about prostate. And at that time in America, they were doing perineal prostatectomy. And it was not only till the late 70s or early 80s when they started doing retropubic radical prostatectomy in 1983 when Patrick Walsh showed the nerves. So you can see how much time even American took in identifying those nerves. And after that, the anatomy became so clear that they could show the dorsal venous fluxes and the lateral part of the prostate was having nerves. So the urologists started dissecting them safely, and this surgery became very popular in America. In India, it was in 1995 or 1996 when this surgery picked up, and after that it is. Please keep your mic on. Please keep your mic on mute. So in India, I was talking, then it picked up as open surgery, and as soon as the open surgery picked up, the laparoscopy came and then the robotic came. So there was hardly any much time for open surgery to, be done by all the urologists in the country. Most of the young urologists, they landed up with robotic or the laparoscopy. We all know that radical prostatectomy is gold standard for organ-confined CA prostate. It is the best way to treat control the local control is the best way. There are other treatment is like brachytherapy, iridium-125 or palladium oncocyte plus minus salvage, radical prostatectomy. They are old treatment now. Nobody does that. Then we have external beam radiotherapy about which Vedang will be talking. Then we have cryo, HIFU, and thermotherapy. They have their own problems of rectoprostatic fistula or may not be may not be very optimal in controlling the local disease when you do the ablative therapy. Now, radical prostatectomy can be done by perineal route or it can be done by the retropubic route. There is another very rare report in the literature is transcoccygeal route, which is now replicated by the robot as Bridges sparing, which I will be showing. It can be done by laparoscopy, but it is not very popular. Only few surgeons in the world are still doing, and they are very good in laparoscopy. Only those guys are doing. Otherwise, not. It's a very difficult surgery to do by laparoscope. Robot has made this surgery very simple and so much so simple that the dorsal venous plexus, which was the main concern during open surgery, in robotic you are not bothered at all. And with robot you can do intraperitoneal, you can go extraperitoneal completely, you can do ridges sparing. There are reports also to do perineal robotic radical prostatectomy from one center in America, that is Cleveland, where Jihad does this surgery. So radical prostatectomy, as any surgery, is the planes. You have to see the planes. You have to know the anatomy, and you have to go in a correct plane, and you have to know the fascia and what are the vital structure. When I started doing the surgery in 1996, I never had any training to do this surgery. I read from the Campbell book of urology, and with that, slowly I evolved my surgical skill. The good thing with me was that I was having a lot of cystectomy in our center. So when I was started doing cystectomy, the anterior dissection was like a radical prostatectomy, and that is why I had more chances to dissect that area. And slowly I picked up, and then later on I had gone to US and watched big people doing this surgery, and then I had refined my technique. Uh, it's one thing which I would like to say, tell the young urologist who want to do any surgery, it's not rather any situation in their life. If you want to have a confidence for any situation, you must actually venture into it. Same is for any surgery or any other profession. If you want to really become confident in doing radical prostatectomy, you must start doing. Slowly you will evolve in a confidence. Otherwise, if you don't do, it will be always a fearful area for you, because moving a needle holder in behind the symphysis pubis, one has to learn. It doesn't come on its own, as it has it can come in the upper abdomen or maybe in the kidney surgery. But in that area, you have to develop your reflexes, which takes time. It doesn't come in one day. And this is how the anatomy was when I was doing MBBS. At that time, there was McNeil's anatomy, the lobes. But if you know that the Campbell has shown in early 2000, the beautiful diagram, and this was the CD which he has sent all over the world. When the young urologists are attempting this surgery, they should know about these vessels. There are branches of interpudendal artery and veins. If you cut them without clipping, this gets retracted into the levator ani, and this will bleed in such a manner that you may probably will think that why did you attempted this surgery at all. These are the puboprostatic ligament, and this is the superficial dorsal vein of penis. This is the cadaveric anatomy of prostate. You can see the prostatic lobe and and then the DVC here. And when you go in some other way, there's the prostate and the DVC, and then the symphysis pubis. So one has to be very careful when you are dissecting. It's an open surgery. I will show you the slide, and robotic I will be showing the video. This is the apex of the prostate. If you are cutting, you should be knowing where the sphincter comes. It comes onto the prostate. But in problem in open surgery is that you have to cut the puboprostatic ligament towards the symphysis pubis. While in robotic, you can go onto the prostate. And this is the photo of an open surgery where you can see those sphincterovenous complex after ligating the dorsal venous plexus, and the urethra is coming. These are the neurovascular bundle. They lie laterally of the prostate, and this is how the dorsal venous vein, it actually fans out onto the prostate and then goes into the intra-iliac vein. And this is the place where you can find many times the difficult cases when you are not able to find the plane between prostate and the rectum. You can go laterally here, and you can cut the fascia here. If you see there is a loose areolar tissue, that's the yellow colored fat will be there, and from there you can come from lateral to medial in open surgery. There's another thing that the sphincter comes like this. It's omega shape, mainly concentrated in the dorsal part. This is the DVC. You can see how bad DVC is, and even in cadaveric thing, these are the facial layer. You can see that these are the levator fascia. There's the denovular fascia, and if you end up in doing extra or intra or interfacial, there are these planes where you can go. I'll be showing in my slide. This is the after cutting the sphincter. After cutting the urethra, you will see the catheter at apex, and you can use these instruments. They are available from Ascolab, and when in Delhi we have locally made instruments for open surgery, and then you can go to the posterior part of the urethra. After cutting the posterior part of the urethra, you must take, before that you must take stitch suture, but after cutting the posterior part of the urethra, you can see that this is the fascia, adenoalveolar fascia, and they are the small vessels. And if you cut one more layer, you will be landing with a small bead, which is not of concern, and that's actually is the correct plane. Now, another thing which I would like to tell all my young urologists who are evolving and who want to do this surgery, you must see this diagram. This is the recto urethralis, and when you are coming from retropubic area, you are cutting here. So you are not coming through the recto urethralis again, you are saving it. But if you are coming from the perineum, you will definitely cut this structure. This will, without cutting recto urethralis, you will not go, you can't reach onto the prostate or into these planes. And that probably is most important factor in return of the early continence when you do Ridges sparing. In Ridges sparing, we come from here, we do not touch recto urethralis, and we remove the prostate like this, and without touching the dorsal venous plexus or sphincter complex at all, we do not touch them. But same thing you do when you come from perineum. But only thing that is different from perineal radical prostatectomy and Ridges radical prostatectomy is that you are coming through the recto urethralis. That probably, I'm just putting this theory. It may be this is the only step which is different when you do the Ridges sparing or you do the perineal radical prostatectomy. In 1905, Young did perineal radical prostatectomy, and in 1947, Millins did retropubic radical prostatectomy. And retropubic radical prostatectomy at that time was also associated with less blood loss, less operating time, less hospitalization, and early patients convalescence. And these are the diagram which can show you how the extrafacial, where you are taking the adenoalveolar fascia and removing with the prostate, and the prostatic fascia and the levator fascia, all the things are coming with the prostate, then definitely, then this is the extrafacial. But if you are going between the levator fascia and prostatic fascia, then there is the interfacial. And if you are going on to the, rather saving in the prostatic fascia, then it is the intrafacial. And this actually saves the maximum number of the neurovascular bundle, which many people have claimed that it probably is the patient will have very good potency results if you go in this plane. And this has to be done in the patient which have very early disease. It cannot be offered to our patient, at least in our context, because we do not do the screening at all. That is why we see a lot of patients who are either T3 or PSA is more than 20, and that is why they are not fit for active surveillance, as Dr. Jahangir has already questioned that why in India and Bangladesh we see the T3 or locally advanced or advanced disease. This is the specimen of an open surgical radical prostatectomy. And this is the incision which I reduced to 6 or 7 centimeter. Lucky for me, these patients were having even they were thin, and we still get such patients. But now we are doing most of the robotic surgery. But when the robot was not there, we were doing using such a small incision. Even we were using transverse incision also. And because we reduced the incision for prostate, we did use 10 centimeter incision for the even for cystoprostatectomy and ileal conduit and new bladder, which is again has been shown by another Dutch surgeon, if you see in the literature. And as far as robotic versus open, it is not a debate now. We know there is an advantage of robot, and because of the very good quality of anastomosis and less blood loss, which you have, the vision and the ease of doing anastomosis, robot actually scores over open surgery. There are other techniques like Ridges sparing radical prostatectomy, which has been shown that there is early return of continence provided, and it has been proved by prospective randomized control trial by Money group. This technique was first described by Bouchardi from Milan, and soon became popular all over the world. A lot of surgeons are doing, but still a lot of surgeons, they do not switch over to Ridges sparing because of a bit more difficult steps in this approach of the operation. I'll go to my video. Just wait for some time. Can you see my video? No. I'll just share my screen. Okay. So
In the meantime, you can have few questions and answer also. While
it
the
is there,
video
sir.
will be going
I
on.
think it is there.
I think it's coming up.
Yeah. So I use three instruments. Can you hear me?
Yes, we can.
Can you hear me?
Yes, you are audible.
Okay. So I use three instruments just to save the money, as this is very important factor in our part of the world. And with the needle holder, I use the bladder, hold the bladder up, and then we dissect the seminal vesicles and the vas on both sides, and then hitch the bladder with the straightened catgut up. So it actually takes away the job of one retractor. This is how it
Good
goes.
idea.
And,
Good idea.
if you are using progress, you don't need not to do this steps at all. On both sides, you can do that. We do it, start on almost all the cases with this technique. But if the patient, if anytime we feel that we are not doing good job, especially if a T3 lesion or there are some other factor, then we go ahead and do the anterior approach immediately. So after hitching the seminal vesicle vas up, we go to the posterior part between the rectum and the prostate, and this has to be done with sharp and blunt dissection. If you go laterally, you will see these nerves, which can be dissected easily with this techniques. And accessory obturator RT does not come with this technique. It actually gets reflected on its own when you use this technique. It takes some time in learning. Otherwise, once you pick up this technique, you really enjoy doing this surgery. This is the lateral pedicle of the prostate. Dissecting some more on apex, and this dissection is always has some oozing all the time, which one should not. Once you have done both the lateral pedicles, you have to go laterally onto the prostate, defining the prostate. Actually, you have to define the prostate before you come to the 6 o'clock or 12 o'clock position. From here, it is probably 6. So you have gone to the laterally, and this is only blunt dissection. If you see any spurter, you can just buzz that with the point diathermy rather than using diathermy all the time. And once you dissect from both sides, you can see the bladder neck and the urethra coming here, and you can cut that. After cutting this, you will see the catheter. And once the catheter is delivered, you must take the stay suture onto the 6 o'clock onto the bladder neck, because this will help you in identifying when you are doing the anastomosis. Otherwise, sometime you may lose this bladder neck, or this hole is a small hole, so you may have some problem. The dissection till we remove the prostate is done by 0 degree, but later on for the anastomosis, we shift to the 30 up, and that helps like anything. So we are cutting now anterior part of the urethra. We can take the stay suture right now, or you can take it later on. It's not a big deal, but because you have another suture already, so you can definitely define, but we are taking right now. Nowadays, we take it later on. We don't change the instrument. And after hitching that bladder neck, you go further onto the dissection onto the prostate at the apex, and you can see some small arterial spurt, which can be buzzed Even if you don't buzz, they do stop many times just without doing anything. You can just injure them bluntly, the artery goes in a spasm. So here you can see that there is no DVC, and I am behind the DVC and going on to the apex of the prostate, taking the facial layer, and during this dissection only we'll be cutting the puboprostatic ligament. Another arterial spurter, and you can just buzz it, but do not buzz the veins at all. Just don't. Even if you open the DVC, there's not a problem. You can suture it with 3-0 V-lock. And once you have dissected apex properly, you can cut the urethra, keeping catheter there, and then ask the assistant to remove the catheter and cut the posterior wall of the urethra and then posterior part of the periurethral complex. It is better to stay close to the bladder neck, but not to compromise the cancer there. If you have anything, you can go a bit distal also. Once this is done, the anastomosis is proceeded. Anastomosis is tricky, and one has to, just have patience to do the anastomosis in these patients in this technique, because the things are reversed. You start from 12 o'clock position, while in anterior approach, you start from 6 o'clock position. And if there is any bleed, you can underrun while using the anastomosis with V-lock without any problem. This ooze and all or bleeding stops when you are at the completion of anastomosis. One should not worry about this small bleed, and you have to take help of your assistants to identify the urethra and to take the proper mucosa to mucosa approximation. The main thing in this anastomosis is the lateral part of the anastomosis. When you are coming from outside, like from like this suture, many times you'll end up in cutting through the bladder. And this especially happens is when I give this step to my juniors. They do struggle with this area, but if with time it comes very easily. I rather enjoy now doing this step, because at this time you have to move your hand really in a extreme ways. Once you have done half of the left side, you go to the right side, but and then before completing the anastomosis, it's better you put the catheter. I generally now ask the assistant, once I have completed the anastomosis, this is one of my first video which I've done this technique, but nowadays we complete the anastomosis and then I ask assistant to introduce the catheter and just make sure that this is watertight, and also there's we have not entangled the catheter with the suture. So this is not the way I finish the anastomosis nowadays. It's in a different way, but you can evolve into your technique, whatever way you want to do that. So it's only 30 seconds remaining. So I will be happy to take if there is any question or comment. Meanwhile, this will get finished. And it can only be done by robot. There are 1 or 2 reports in the literature people have shown with laparoscopy. I don't know. I'm not a laparoscopic surgeon, so maybe later on people might evolve into the laparoscopic technique when they get some better instruments. Thanks a lot for inviting me and having me part of this meeting. Dr. Salam and Dr. Jahangir, Dr. Kamal.
Thank you, Dr. Rawal. This nice deliberation and excellent summarization of all in short time. So we will discuss all these issues later on. And I think Professor Gupta is here. He has started the robotic surgery in India at first. So just a quick comment from him, whether he want to add anything on at this time or want to discuss later on.
Dr. Jahangir, you can ask opinion from Mark Solway as well. This is an unique opportunity.
Okay. Thank you, Dr. Salam, Dr. Jahangir, for your invitation
Thank you very
to join
much.
this meeting. Dr. Sudhir Rawal has given a very good description of the history of the radical prostatectomy, and what he has stressed, and I will also like to stress that anybody who want to start doing radical prostatectomy, whether open, laparoscopy, robotic, they must go through that video of Professor Patrick Walsh, which he released in year 2002. I think so. I have never seen such a wonderful description of the anatomy. And when we started doing ourselves in 2000, we have started doing radical prostatectomy at All India Institute of Medical Science Open. At that time, I always used to see that video previous evening. The next day morning, I used to practice. So that is my advice to all my younger colleagues, those who want to start, please go through that video clip. If it is not available, ask us. We will send you a copy of that. The second thing is about the robotic. I think so. As we are more habitual of doing a extraperitoneal and transperitoneal, so we do all transperitoneal robotic radical prostatectomy. We started in 2006. At that time, probably Sudhir was doing the open and laparoscopy, and then he started in 2010. So, but we have to master one technique. I think so it doesn't make much difference whether you are doing extraperitoneal, you are doing transperitoneal, or radius sparing. There may be a minute difference in the continence. Otherwise, if you have mastered a technique, I think so that gives the very good result. And you have to always assess your own patient, what mistakes you have done, how was the outcome, and then you go on improving case after case. And there is a learning curve for doing a radical prostatectomy, either of these techniques. So don't change too often the techniques, but once you become master, then you can think of going for another modification of that technique. That is the advice from my side. And over to Dr. Mark Soloway. He may like to make some comments. Dr. Soloway, please.
Professor Soloway, just have a quick comment from on this regard.
Dr. Jahangir.
Yes, sir.
Dr. Motar has a case on the table in US. So he would like to do it right now. If he can do it, then he can be.
He's on the list now.
Yes.
Yeah, just must from comment from Soloway, and then we'll.
Mark Soloway. Yes. Thank you. Okay.
Professor Soloway, can you hear us?
Yes, I can. I thought there was a wonderful video. I was interested that you do the transverse incision, which I did for many, many years. I liked how you did the bladder neck sparing. I'm a big believer that whether it's open or robotic, you should spare the bladder neck. The only thing I would mention is that I think people overestimate the potency. I tell patients, every patient, regardless of age, that don't expect to have excellent erections. The last thing I want is someone coming back and say, oh, you promised me 80, 90% chance of potency. So I think that's the most important thing in discussing the alternative treatments. But I thought the video was great and very well done.
Thank you, sir. Thank you, sir. Now we have with us Dr. Muthar Ahmed. He is the Director of Bladder Cancer, Hackensack University Medical Center and Clinical Research Professor of Rutgers, New Jersey Medical School. He's son of our soil. He migrated to USA a long time ago, and he became one of the popular robotic surgeon in his territory. So, Dr. Muthar Ahmed, please. He will be talking on innovation in robotic surgery. Dr. Mudhar, can you hear us? Can you unmute?
We can see the screen.
Can you hear me now?
Yes, we can hear you loud and clear.
Excellent presentation of space of Ritz is sparing by Dr. Soderall. Really enjoyed that video. That was very nice. I'm going to talk about prostate cancer as well and how to approach it surgically and some new way of doing it. as well as the single port extraperitoneal prostatectomy. This is the brand new stuff that is we're toying around with the single port robot. So we'll go quickly. Let's see. All right, so this is a very famous picture. I'm pretty sure Dr. Soloway knows this picture very well. This is our institution. This is the robot, where it started and what generation we're in. We started in 1999, and now we're in 4th generation, which is the Da Vinci Xi, which is available pretty much everywhere in the US. And I think some of our Asian partner, they're also getting Xi in different form. This is the brand new generation. It's actually 5th, but it's not really a 5th generation. It's a totally different platform. It's a single port. So you could see all the ports goes in through this 3 centimeter port. We'll talk about that a little bit. So for robotic assisted laparoscopic prostate, we know from retrospective and prospective data that there is 3 key benefits, and the speaker already mentioned that, so I'm not going to go into this. But we know the robot is here to stay and is going to take off, and it already has taken off in prostate, in kidney, in cystectomies, and in reconstruction world. So I don't think that debate is there anymore. This is a tool that we have, and those of us can master it, can really do some wonderful stuff with it. So this is our SI. So that's the system. I'm pretty sure we have it in India. We have it in a lot of Asian countries. This is the SI, 1 generation before the XI. And the difference is this one has a 12 millimeter camera port, as opposed to this one, which is the XI. It has 8 millimeter camera port. So the camera can be interchanged between this one, this one, this one, this one. So for taking down the adhesions, you don't need a laparoscopic camera, because this camera, you could put it in any port and can work yourself around it. So this is one of the key advantages of the XI, aside from other mobility that it provides. This is the XI, how you already have this is the assistant port, this is the one working port, another working port. Sorry, the camera, working port. But again, this camera can be interchanged between different ports. This is the SP. So that's the newest of the new. And the difference is we're still figuring out how to use it, but I've been using it for a year. I have done about 150 cases, prostate cystectomies, partial nephrectomy, nephroureterectomy, reconstruction, but we're figuring it out. This is something that we figured out, that there is a clearance you need from the port placement to the where this arm can extend and can bend. So a lot of these cases has to be done with that. You all know the hand port gel, but this is a smaller hand port gel that gives us that extra space, and you could basically have the robot outside the body, and that gives you the distance to work on a narrow space or a short distance space. And that's how we can do extraperitoneal prostate. I'll show you on the video. This is how it looks like after you duct. All the ports are going in through this. We have our air seal, or the insufflator is going through this, and which is also going through the gel port. And again, so everything is through a single incision, which is the gel port is going through. And this is a incision after doing an extraperitoneal prostatectomy. No drain, just 1 incision, about 1 inch long. This is amazing. This is how a posterior urethra looks like. This is an old picture, but I just want to show you the anatomic, how the dissection is done. Dr. Soderal will show you space of Ritz's. This is going from, this is actually an interperitoneal going above. And this is the urethral dissection, the apical dissection. You could see the nerve, you could see the urethropexy stitch. Although I will show you on the video that we changed some of this thing a little bit and doing it a different way for efficiency. This is an athermal nerve sparing. And this is how it looks like after anastomosis is done, equal caliber bladder, neck, and urethra. You can do these prostate in any form, any shape. You know, we all know the prostate comes in different shape, different size, median lobe, lateral lobes. And this just show you an example of a specimen, how it looks like. This looks like a tongue is sticking out. So what's new? This is what I want to focus on here. So what's new is less is better. So with increased understanding of the anatomy of the bladder, neck, and the apex, we have learned to reduce steps. And I've been doing this way for the last 5 years. And the idea behind it, you really have to learn to use the 4th arm really well. minimize changing of the robotic instrument. Now we know how to do robotic prostate. We've been doing it for a long time. So now we're trying to see how can we cut costs? So if you use 2 needle driver instead of 1, that's $250 more. If you use extra thermal dissector, that's another $250 more. So how can we reduce? So on our cases, we use only 4 robotic instruments for the entire case. And that's basically it. So learn how to use it, only use 0-degree lens, don't have to use 30-degree unless you really have a deep pelvis. And robotic time for radical prostatectomy, we have cut down to under an hour in most cases. Difficult cases, maybe 15 to 20 minutes more, and reduce. If you know the anatomy well, you don't have to do a frozen section. Frozen section is done if you think the cancer is outside. But if a surgeon has to do a frozen section to see if the adenoma is left behind, that's a problem. So that's really an understanding of the anatomy, which is absolutely important, as Dr. Soderwall mentioned on his lecture. So what we have done is that we don't put any more dorsal vein suture. We don't do any staple control. We don't put any stitch on dorsal vein. We cut it the way Dr. Walsh has shown us in the open technique. No need for Foley tucking. You know, a lot of people you'll see when they do intraperitoneal or coming from the top, they will hold the Foley to hold the prostate up. You don't need to do that with this technique. Not to take the endopelvic fascia down. We do it with one step when we do the nerve sparing. You'll see on the video. Develop posterior lateral plane to really drop the nerve. And spare the nerve retrograde fashion and then take the endopelvic fascia at the same time. And use single clip on each side of the pedicle. You don't need multiple clipping. And peeling the nerve off from the periprosthetic fascia is the key. And eversion of the bladder mucosa with a single stitch. I'll show you on the video. And with these techniques, all my partners and other urologists in our areas have come and watched, and they have started to adopt these things. So it is reproducible. And you know, data shows that faster recovery of urinary control and erectile functions, but definitely it saves time and money in the OR. And this is our efficiency scale. You could see that that's actually mine. And you could see that for a XI prostate, the entire operative time is about 89 minutes, and 122 is the entire operative time. Entire time the patient spends in the operating room. So only about 2 hours from the patient coming in, getting intubated, leaving, and getting extubated and going to the recovery room is about 2 hours. And this is with SP. SP is a newer technology. Obviously, it takes about 10 to 20% of the time more. So in there, you could see it's about 113 minutes of operative time and 156 minutes of room time. So again, this is another graph showing, compared to other academic peers, where the way I do this technique, where the time-wise and the cost-wise is all the way to the left side, that is the time factor, and the cost side is also pretty much at the average time. Now, that was before I eliminated using one extra instrument. When I did the new analysis, it comes down to right here. So you could see that you could take these steps to really save money and save time in the OR. So I'm going to show you a quick video.
In the meantime, Dr. Matahari, you can answer to one of the viewers' question. This is an extrafacial or intrafacial?
This is, I'm going to show you, this is a combination of both. Actually. Okay. Let me pull
Thank you very much. There will be many questions. Prepare for that.
Yeah.
If you can spare some time, this will be very beneficial for the audience.
So, here you could see that this is an interperitoneal prostate. So we have dropped the bladder down. What Dr. Soderwall showed, he worked from below and saved the space of Ritzes. This is not saving the space of Ritzes, but this is opening the anterior bladder. You see no tucking of the Foley. You kind of know from the anatomy, from the fiber of the bladder and the prostate, where the neck is. It kind of gives it away. If you pull it and do a nice traction and you burn, you know exactly where the bladder neck is, and you could make an adjustment. So I always tell my resident, look, we started here or we ended up there, because that's where the body is telling us to go. It's not a fixed point. It's a very fluid, the bladder neck is fluid. You have to know where that fiber is to know exactly where the bladder neck is. So again, we already cut the posterior bladder, and now we're working on top of the seminal vesicle and the vas. And again, using the fourth arm, this part was already done. Now we're opening the posterior, which Dr. Soderal did initially. And here we're going to show you the endopelvic fascia, which we didn't take before. Now we're going to take it at the same time as we're going to do the nerve. So we're taking the endopelvic fascia right now, and now we're going to work around. This nerve sparing is a tricky business because the nerve, you have to go behind that vein, that periprosthetic vein. Because if you leave the vein on the prostate, you're not really going to save the nerve. And by doing the dissection posterolateral, we already have opened that window. And once we cut endopelvic fascia and get behind the vein, the nerve is already dropped. And you could see we just come around with our bipolar, and that's it. That's the one pedicle technique. And what's going to happen, I'm just going to thin it out a little bit by using some electricity. And once it's enough thinned out, we'll have our assistant put the clips on. And we already did the other side. You could see it's already done. And there's a clip. So it's a one clip on each pedicle. And you'll see once we get rid of that, you'll be able to see the nerve and how it was dissected retrograde fashion. And so now we're going to show you the dorsal venous complex. So same case, the nerve and the pedicle is already dropped. So you see there is no stitch on the dorsal vein. We're just going to cut it sharply and a little bit of electricity. And especially posterior lateral, no electricity. We use athermal. We tolerate the bleeding. And anteriorly, you could use some electricity. But you could see these venous sinuses, they're open, but they tend not to bleed because we have the pneumoperitoneum. It's about 12, 13 of interperitoneal abdominal pressure. That reduces the bleeding from dorsal vein. And you could see this is a pretty young, healthy patient. You could see these sinuses, they're pretty large, but they're not bleeding. I'll do some active bipolar coagulation, and then we'll just cut it. And you could see it's not massively bleeding. And this nerve was already done. Now here, when we do lateral work, you try to use less electricity. And this is already done. You could see a nice apex. There was no apical dissection needed, and there was no dorsal vein suture was needed at the start of the case. And no endopelvic fascia was taken. And some of us, have described variation of this. Dr. Astuari recently describing a hooded technique, which is similar, but he leaves the entire endopelvic fascia on and just carries on that way. And now we're taking the anterior urethra. So it's similar to what Dr. Soderal shows. It's just the backward. It's coming from the top, which is most of us are familiar with this anatomy. And so the vesicle, and you'll see here when we do the anastomosis, we're going to include, so posterior anastomosis is already done. We're going to include the dorsal vein on our anastomotic stitch. So that way, if it was going to bleed later, it will not bleed because that will compress the dorsal vein complex. And it's done with one step while you are doing the anterior anastomosis. And it's a nice caliber. It matches up with the urethra. And we are completing our anastomosis. And I'm just going to speed it up a little bit for interest of time. So this is a summary, basically. No need for dorsal vein suture. No need for Foley tugging. Develop posterolateral plane well. Combine endopelvic fascia with lateral dissection and retrograde nerve sparing. Use single clip for each pedicle. Include DVC in your vesico-urethral anastomosis and use one needle driver. Use the bipolar as your other needle driver. So that's pretty much it with this one. Now I'm going to show you a quick video of the SP video. There you go. So this is a single port prostate. So you'll see that how we dilate the space. This is the newest of the new technology. And there you go. So this is an extraperitoneal. Here we are dilating the space right below the umbilicus, above the posterior sheath. You know, it goes about 2 inches probably toward the pubic bone. Then there is no more posterior sheath.
We cannot see the video.
We cannot see your video now.
Yes. Oh, you can see the video. Okay. I'll share this video. 1 second.
Start from little
You know,
behind.
I'll do it right here. There you go. You could see it now, right?
Not started yet. Yes, yes.
Can you see it now?
Yes, yes, I can see now.
Yes. So this is the extraperitoneal space development. Again, some people use balloon. We use the finger dilatation because this single port, the robot is coming straight in. So you don't need that much space. So that's the great thing. I love extraperitoneal prostate. But because of the multi-port, I wasn't able to do it because most of the time I was getting into the intraperitoneal space. But with the single port, you could get into the extraperitoneal and you could stay in the extraperitoneal space. So that's the advantage of the single port. Now, Dr. Kao described also perineal prostatectomy using the single port robot. But a lot of us are not that familiar with the perineal anatomy, so I'm going to leave that aside. But this is the extraperitoneal that is great thing. It's allowing me to go back to doing the prostate extraperitoneally, which we have done throughout our life. And especially our senior professor will tell you they have done prostate extraperitoneally all their life. And we're taking an extraperitoneal organ and doing intraperitoneal surgery. So this brings us back to the extraperitoneal world. And it's easily reproducible. Again, here, you don't have because I want to do this thing through a single port, I don't use a +1. Some of my colleagues, they're using a +1, which is putting another 5mm port and using that as a suction and for retraction. But we don't do this here. We're using a flexible sucker, like a feeding tube, to assist us in suctioning. Here, you see these arms, they bend at the forearm. They don't have a wrist movement like our XI or SI. So that's the give back. That's the negative criticism of this machine, that we lost our wrist control. So a lot of my colleagues, they'll say, why I want to use this when I'm giving away some of the good things the robot has given me. It is true. But my argument is we need to use new technology. Long as we can reproduce, even though if it is a little difficult, but the flip side is that we can give feedback and they can improve the machine. And I'm pretty sure the next generation will be a lot better than this one. So again, we're doing this thing completely extraperitoneally, but it looks like we're doing it intraperitoneal because the space is already created and it's already developed.
That's great.
Right, I mean, you realize that this is completely extraperitoneal. And so this is again developing the posterior plane. Now you'll see here that we really, that's what I'm talking about, really develop that posterolateral plane. That's the plane you need to develop, not to give up too soon. Some of my colleagues will give that up too soon. No, you got to really develop that plane because that sets you up for the nerve sparing later. So here we're doing the left-sided nerve sparing. You saw the right side before with the XI. This is the SP. Again, same idea. Now here we don't have the assistant sucking, doing the suctioning, so we'll have to. But again, thank God it's not bleeding that much. But we have that little suction in case we need it. So there you go. And now you'll see this one, you cannot bring the entire bipolar around because it's a smaller machine. So here we're going to clip, and this is a robotic clip applier. And unfortunately, we have to probably clip twice because these clips are smaller than the handheld clip. So you got to interchange the instrument because the clip doesn't go through those assistant ports. So here, controlling the apex, same thing, although we have a different machine, but same technique that we're going to not put a dorsal vein suture, and we're just peeling the lateral stuff off here. When you work on the lateral, posterolateral, don't use electricity. Now this is the right side again, we're putting clip, and again, it's similar, exactly similar to the other procedure. Again, here we're not putting dorsal vein, the apex initially, and here it's exactly similar technique. So I'm just going to move forward. So here, when you do this technique, you have to know the anatomy. Whatever technique you use, sparing rectus space, extraperitoneal, intraperitoneal, doing posterior first. You have to know the anatomy of the prostate. This is the key. This is just showing the lymph node dissection. So that's pretty much it with the video. Now you could ask some questions. Yeah, so the summary is, technology is evolving fast. We're doing them open. We did a laparoscopic. Then we got robot. Robot has made prostate easy. Then we got newer generation of robot, which makes it even easier. Now we got SP, which is a brand new platform, which is a bit more difficult. So some people will argue you taking an easy surgery and making it more complex, but the benefit is one incision. Benefit is less pain. Benefit is they can go home on the same day, essentially. And we have to use it to give you feedback so we could get a better machine.
Dr. Muhtar, how much is the cost difference between the XI and
similar price?
Similar
the
price.
Investment is similar.
Do you think that who is conversant with laparoscopic surgery, they will be able to use the XI, or they have to have some experience with the XI before going into single port?
I think they are two different machines, but definitely it's easier to use the XI or SI than use the single port. But
I see. Yes, the point is taken.
Probably how you make the transition. I don't think it's going to be difficult if somebody never used the XI and they just go to the SP. Maybe they're going to feel it's similar.
There is a question from the audience is that you go always extraperitoneal or transperitoneal approach with your single port?
When I do the SP, the single port, I use the extraperitoneal because I like extraperitoneal. That machine allows me to do it.
Okay. I'd like to ask a question.
Yes,
partial
please.
extraperitoneal. So it's allowing you to stay extraperitoneal for extraperitoneal.
Dr. Mutahar, do you select your patient for single port like a small size prostate? And if suppose patient has got a large prostate or it has got a post-TURP or HOLEP, then you think that a single port is feasible or not feasible?
So that's a good question. So I don't cherry pick. Initially, maybe I cherry pick, but right now I don't cherry pick the patient. I have a block time for single port, which is Friday. So wherever I can get on that day, I'll do those cases that day. I have done few post-TURP with single port. They're okay. It's similar the way you approach your other case. This is similar, except that you have a little bit of restriction with the instrumentation, and you compensate that by doing other things. That's basically it.
Can I make a comment?
Yes, sir.
Yes, please.
Yeah, only thing that I would like to say that I think a single port I have.
Is anybody any question on what, because he's been doing for the surgery? So if there is no
Thank you for having me. Please.
And our next speaker is Dr. Vedant Murthy, and he is from Tata Memorial Hospital. He is the head of radiation oncology there. And may I request Dr. Vedant Murthy to start his presentation, please. Dr. Vedant, please.
Good evening. Good evening.
Yes.
You can hear me, I believe.
Yes, please. We can hear you.
Good evening, everybody. Dr. Jahangir and Professor Salam, thank you very much for giving me this opportunity. I really enjoyed actually seeing the surgical videos, and it's good to see our urology colleagues with some shiny new toys. I thought we were the only boys with toys, expensive toys, so it's good to have that company as well. So I am a radiation oncologist. Probably most of the audience is urology here. So I work in Tata Memorial Hospital.
There are many oncologists as well.
All right, good. So, rather than doing a master class, I thought because this is a mixed audience, I would rather treat this as a prostate radiotherapy 101 and try to answer a number of interesting questions that one may have as either as a urologist or oncologist, like really is radiotherapy effective in localized prostate cancer? What should be a good dose to treat? What kind of technique should we use? Can we use an older technique like 3D CRT today? And is image guided radiation really important? And some issues related, basic issues related to fractionation. And interestingly, in the end, I'll talk to you about toxicity as well, what it means to the doctor and to the patient. And I think Dev Narayan will talk about the SBRT later. So we have so many questions. So let's get on with trying to answer these. So is radiotherapy really effective in localized prostate cancer? And so when we say effective, we have to compare it with surgery and active surveillance or active monitoring. And you have seen this slide before, but there were a lot of single center and multi-centric retrospective and prospective data till very recently, saying, I mean, with various biases, confounding factors, etc., comparing surgery with radiotherapy. But this trial kind of set a benchmark, saying this was done by the Brits. They randomized more than 1,600 patients. You know about this PROTECT trial, to have monitoring, prostatectomy, or radiotherapy. And what did they find? Essentially, there was no difference between the three arms as far as the outcomes are concerned. And you're also, most of you would be aware, the surgery and radiotherapy were equally effective. Mind you, these are mainly low-risk cancers and some intermediate-risk cancers. Overall, the outcomes were excellent in both arms of treatment, and both of them were safe. So this kind of proves beyond reasonable doubt that yes, radiotherapy is an effective treatment for localized low intermediate risk prostate cancer. Now, this is a very important is it okay to give only ADT alone? I'd really like to address the young urologist here in the audience. Often we see, I mean, I'm sure everybody sees, unfortunately, even today, certainly even in India, and I'm sure even in Bangladesh, a patient with localized prostate cancer often gets ADT alone, either as an orchidectomy or as with medical castration. So is it enough? Two trials actually have addressed this issue, that whether what